Hello, everyone, and welcome to our Fertility Network UK webinar this evening. We're going to be looking at egg and embryo quality today. I'm Kate from Fertility Network UK, and I'm joined by Rachel Cutting, who's the Director of Compliance and Information at the HFEA. And Rachel actually began her career as an embryologist, so knows a lot about these things, and by Professor Tim Child, who's a consultant at TFP Oxford Fertility. If you've got any questions, you're very welcome to answer them. Just put them in the Q&A or chat box. We have got quite a lot in advance, but we'll get through as many of your questions as well as we can. We are recording the webinar, so it will appear on our website in the next few days. Don't worry if you want to ask questions, they will be completely anonymous. We won't read out your name. Just a quick reminder before we start that we are a charity and everything we offer is completely free of charge, but we would be very grateful if you do feel able to make a small donation. And I'm very excited that for the first time we actually have a text to donate. So if you want to make a one-off donation, it's really quick and easy. You just need to text FNUK to 785 and put the number of your choice, the amount of money you want to donate after the FNUK. So if you text FNUK 5 to 785, that will make a one-off donation of £5. But I'll remind you about that again at the end of the webinar. But I think we can actually start now. Rachel, I wanted to start by asking you the really fundamental question. How do you know if an embryo is actually good quality?
What happens when you've produced your eggs and you've created embryos in the laboratory is that the embryologist has to look at those, because usually you produce more than one embryo, and of course every embryo will develop differently. So what the embryologist does is then look at those embryos in a closer detail to see firstly how their rate of development is going. So for example, on day 2 we'd expect an embryo to be between 2 and 4 cells. On day 3, 6 to 8 cells. And then a lot of times now we culture to day 5, what's called a blastocyst. So that's really important to start with, that an embryo has to develop at the right rate. The embryologist can then, down the microscope, look at the shape of the cells and how they look, and especially when we get to the blastocyst, how the cells have divided up into different structures. The blastocyst is quite a complex structure, so we can really get a good indication of the quality by looking at it at the blastocyst stage. Of course, there is new technology which allows us to look in a lot more detail now, such as time lapse. Until recently, if you wanted to look at an embryo, you had to open the incubator door, take it across the lab, look underneath the microscope, write down everything you saw, and then take it back. And it's very much a snapshot in its development. Time-lapse enables you to look at it growing the whole time that it's in the laboratory. And we know from looking at the videos, embryos can do strange things sometimes that we would never have picked up before. So what we can do is piece all this information together in a jigsaw and look at the information we've got to then try and allow us to select the best embryos for the transfer, and then those that are good quality embryos to transfer. It is important to remember, though, the embryologist is just looking at the shape of the cells. We not actually know the genetic health of that embryo. So although it's good quality, the embryologist can't make that assessment without doing further testing. And I'm sure we'll discuss that later, but that would be a different, PGTA it's called, to look at that. But basically the embryologists are trained to try and pick up good quality embryos by looking at them.
So if you've got mature eggs and the sperm's fine, why would an embryo be poor quality, Rachel? Because I know people are often told, oh, this embryo you've got is not particularly good quality. Why would it be? What makes an embryo poor quality when the sperm and eggs are okay?
I suppose when we say that the sperm's okay, we're looking at a good sample, the sperm's moving. When we're looking at an egg, it's mature. But a mature egg just means that it's at the right stage of development, so it can be fertilized. And of course, again, it's really difficult to answer whether an egg is good quality because we're only looking down a microscope. We can just tell whether it's mature or not. So it is quite hard to say how an egg that looks okay would produce good or poor quality embryos. Obviously, age has a lot to do with that. With reproductive age, the quality of the eggs go down. That's because of the genetic health. But it is a difficult thing to say about how egg quality is. So Tim, probably.
Tim, would you have anything to add to that?
Yeah, it's a very common question that patients understandably will ask, and I'll really just echo what Rachel has just said. from the lab point of view, when we talk about quality, it's very much just how it looks from the outside. And we know nothing really about the inner qualities. Sometimes I'll say to patients, it's like just someone walking past your window and taking a photograph of them. And from that single snapshot, if you're using traditional type of embryology, deciding what the inner quality, what's going on inside that person is like, obviously you can't do that. And also the same is true, as Rachel said, for eggs and sperm, how they look on the outside doesn't really tell us about the inner quality. So I often reassure patients that we have patients where the eggs or the sperm look reduced quality, but the embryos are absolutely fine, and vice versa, where the embryo quality is reduced and the eggs and sperm look absolutely fine. And that just goes to show us that how they look on the outside is part of the story, but it's certainly not the whole story.
And how much is quality related to people's age? Because sometimes patients who might be older still have quite a good ovarian reserve when they have those tests done. But if treatment doesn't work, could it still be due to age, even if you've got a good ovarian reserve, Tim?
Yeah, I mean, the main factor by a long way affecting the success rate of natural conception and any fertility treatment is the age of the woman's eggs by a long way, as Rachel touched on, because that affects the genetic quality inside the eggs. And if an egg has the wrong number of chromosomes within, i.e. it's abnormal, the embryo will have the wrong numbers of chromosomes in, but that embryo could look absolutely beautiful down the microscope and could be put back. And embryos that are chromosomally abnormal usually don't implant, or if they do implant, they usually miscarry. Sometimes they'll continue on into pregnancy. That's quite unusual. So it's really the woman's age, which is a big factor in the chance of an egg and therefore an embryo being chromosomally abnormal.
Yeah, and on that, I suppose, women get born with a finite number of eggs. It's 1 to 2 million, and that's it, isn't it? And every month that number diminishes. And at the age of 35, I think you've only got 5-6% of those left. So it's not that you can continually make eggs. They're there from, before you're born, and you're stuck with that number of eggs. So, and as you get older, the way that those eggs work doesn't work as well.
Talking about egg quality, Tim, I know that there's a lot of talk about kind of things that people can do to improve their egg quality, whether that's kind of, avoiding toxins or special diets or things like that. Do any of those things make a real difference, do you think?
It's very difficult to know. I mean, we know there are some things there are some environmental factors that we know affect egg number. So smokers have lower numbers of eggs on average than non-smokers, and also would appear to have lower IVF success rates, which therefore may be because of smoking in some ways affecting egg and therefore embryo quality. So that is why we always advise fertility patients to avoid smoking. That's male and female fertility patients. That is why across the UK, those people who are lucky enough to have NHS funding for IVF, all the CCGs say that it's just for non-smokers, and most of them will say non-smoking for 6 months or more. So there are environmental things that can affect quality. In terms of taking supplements in terms of avoiding toxins and that side of things, when I've read stuff about avoiding drinking water from plastic cups like that or bottles or whatever, and I think there's really no evidence for that, and I think it's very difficult. So it's very easy for people to write a book or to write a comment or an article extrapolating something that's been shown in mice when mice are given really high concentrations of a chemical into thinking, well, therefore, if you drink water from from plastic cup, that's the same problem. So I think, just to finish off, I think in general, I'd say if there's something that you're worried about as a patient and you feel happier or more in control by avoiding using whatever it might be, by taking whatever toxins out of your diet, that's great. That's a really positive thing you're doing. That doesn't mean that me as a doctor would say to you, you should do it, because I might think, well, there's no evidence for that at all. We try and keep things evidence-based, but that's irrelevant. If you feel better for doing that and you feel, as I said, more in control, then there's not a problem at all.
Rachel, what about embryo quality? Is there anything that can be done in the lab to improve embryo quality?
Again, it goes back to the egg quality that the embryos are created with. We can't suddenly improve embryo quality in the laboratory. What we can do is make sure that the conditions are absolutely optimum for those embryos to develop, because certainly in the lab, we don't want to make the quality any worse. So, there's been a huge amount of research and work done to optimizing the culture conditions for embryos. So although we can try and keep the quality as it is, we can't change the fundamental quality of the egg and the embryo as it develops.
We've had a question here from someone who's talking about embryo testing, saying embryo testing isn't offered as routine to increase the chances of pregnancy, but as only embryos that make it to blastocyst are transferred, that would suggest that quality makes a difference. So might it be a good idea to test embryos? Rachel, should I come to you on that first and then maybe to Tim?
Yeah, I can start, and I'm sure Tim will be able to add more to the answer. We do grow embryos to the blastocyst stage, and that's because it helps us select those strongest embryos, the ones that are developing well in the laboratory. And we know from some of the research that's been done, if you're a younger patient, your first cycle of treatment, when you look at the research, there isn't the evidence overall that for anybody going to IVF treatment, it would make a difference. There's some good information on the HFEA traffic light website, and it shows that there's limited evidence to say it would benefit for everybody. But there are certain groups of patients though it may help. So if you're an older patient and produce quite a lot of blastocysts, when you get to 40, 80% of them won't be normal. And what that help then does is select the one out that is. And Tim, if you've had previous miscarriages, it's useful as well. But, just for starting off, I don't think you would recommend it, would you, Tim?
No, I think so. From a genetic testing of embryos point of view, in fact, I was in a webinar yesterday with one of the main people from the continent who they do a lot of it, but even they admitted that for the majority of patients, genetic testing of embryos, looking for embryos with the right or the wrong number of chromosomes, surprisingly, is of no benefit, because logically you'd think, well, it has to work. If you have produced 3 embryos and one's normal and 2 are abnormal, then doing biopsies and looking for the embryos must make a difference. But randomized studies have been done where half of patients have had embryos biopsied and half haven't. And for patients in their 30s, there really was no benefit at all. And it's very, very late 30s or into the 40s, maybe a benefit, maybe people with the history of recurrent miscarriage, as Rachel said, but it's a bit of a gray area. That's why it's red on the traffic light system, HFEA traffic light system, which means for most fertility patients, there's no benefit in terms of improving the chance of having a baby.
That's really useful to know. Just to let everyone know, if you do want to ask a question and you're worried about other people seeing your name, you can just type it into hosts and panelists rather than to everyone, so everyone doesn't have to see your question. And we've got quite a few questions coming in now. We've got another one here about, I seem to get a lot of eggs, but a large proportion of them are immature. What can I do to help this? Is it likely to be an egg quality issue or a medication issue? That's, I think, one for you, perhaps, Tim.
Yeah, so during a normal menstrual cycle, a woman with regular menstrual cycles will be producing quite a few little follicles in her ovaries, and then one of the follicles will become mature, and then usually there'll be one mature egg that will come out. So it's mature eggs that we need in the lab. Rachel needs in the lab for IVF. So when we do IVF, we give the injections of drugs to try and make lots of mature size follicles. So if I'm referred a patient who's perhaps has had IVF, and this is a scenario, so she's had a number of eggs, but most of them are immature, the first thing we do is to look back to see what happened during the stimulation. So were all of those follicles very, very small? Maybe there were only 2 big follicles, and that's where the 2 mature eggs came from, and there were lots of small little follicles, and that's where the immature eggs came from, in which case it wasn't a very surprising finding. In which case, in the next cycle, you would look to see, can you alter the stimulation type of drug or the dose, just to try and do things differently to get more larger follicles. If, however, the follicles were all very large and it was really surprising to get immature eggs out of these big follicles, that can suggest perhaps an underlying egg problem, but also it is important to look at the type of drugs that we use for stimulation. Sometimes patients will come in if they've had that, and they'll say, well, can we mature the eggs in the laboratory, which is something that we have done a lot of in the past. In my experience, people who repeatedly have a problem with a high number of immature eggs, if they come out of the body immature, they generally don't mature in the laboratory. It's not something which is a very good treatment. That's a treatment called IVM. It doesn't tend to work very well. So just in summary, I think if that is a problem, it is important, if you're having a review, to look at the size of the follicles, the types of drugs that were used, the type of late night trigger that was used, and there may be something that can be tried in another cycle. But if it is tried and it happened again, it may be an underlying issue within the eggs.
And would every clinic do that routinely, or is it something, this kind of review of all of the, how the cycle has gone, or is it something that people would need to go in and ask for?
I mean, every clinic should do it routinely. I guess there's always a danger in presuming that it's being done. And I think that's why it's always very important that after a failed cycle, whatever type of failed treatment that is, that if there should be an opportunity for the patient and partner, if there is one, to speak with the clinic about what happened, to go over things very carefully. Now, it may well be, and usually, to be honest with you, usually if a treatment hasn't worked, usually it's down to chance. And very often we'll be saying, look, it was chance, it was bad luck. Let's try the same thing again. That doesn't mean that we're just being stupid and trying the same thing again. We just think it was down to chance. If, however, something unusual happened, as we've just described, then there may well be things that can be changed to try and tilt the odds more in your favor.
Great, that's really useful to know. Another just quick one for you, Tim. Are there any supplements that my partner could take that might make a difference to sperm quality and therefore embryo quality?
So I sort of briefly mentioned supplements before, but I think the problem with supplements is, not a problem, the issue with supplements is because they're not drugs, they've really not been tested in the same way that, so if a pharmaceutical company invents a new drug and is trying to sell it in terms of prescriptions, they have to go through literally hundreds of millions of pounds worth of testing and studies to show that there's a benefit. For supplements, because they're considered food supplements, there's really almost no regulation about this at all. And the manufacturers can claim pretty much anything they like. So sometimes you'll see that so-and-so supplement has been used in mice and it improves the sperm count of mice. Now, whether that improves the sperm count of your partner, if your partner's a human and not a mouse, then I guess might be a bit questionable, I suppose. I think the main thing to focus on would be lifestyle. So if a man is, if his weight is outside of the ideal BMI range, if he's a smoker, if he's drinking too much, just try and normalize things as much as possible, I think would be the most important thing. In terms of supplements, it's not going to do any harm, I guess. So, but often I would suggest just using the straightforward ones you can get from a chemist. You can go spending a lot of money on these things. And to be honest with you, I think very often the stuff inside them is the same as the stuff that you get from a chemist. So to go into a chemist to explain the situation, and so one of the well man or pregnant care type ones, which are relatively cheap, I think may help and won't do any harm.
Just on the subject of supplements causing harm, we've got a question from someone who's got a diminished ovarian reserve and has just started a plan, as suggested in a book about egg quality, is now on 13 tablets a day and is worried that this could end up doing more harm than good. I mean, is there sometimes a risk in taking too many supplements?
I think, and again, that's quite a common, it's a very good question. If something is being sold because it has a benefit, there has to be a flip side to that. I mean, nothing can just be one-sided. That's impossible. So if something is being manufactured and sold because there is a benefit, there has to be a risk, whether it's an allergic reaction or taking too much of it, overdosing, whatever. So we're taking 13 different types of supplements. I mean, probably there's no harm in that, probably. But it's very hard to say because, again, these aren't drugs. We don't know what the interactions are between things at all. So in my practice, I would be advising against that. Again, I don't know this, obviously, the personal situation of the person who wrote the question, but it'd be extremely unusual that we would have patients taking anything like that at all. And maybe sort of 1, 2, or 3 would be the maximum. Anything above that would be pretty unusual.
Great, thank you. Going back to men, we've got a question from someone asking whether it would be a good idea to have additional tests for male fertility for things like varicocele, for sperm DNA fragmentation, and could these improve embryo quality? Rachel, what do you think about that?
I can answer the question about DNA fragmentation. There's been a lot of research and work around DNA fragmentation. The way that the DNA is packaged in the sperm head is very complex, and you can use tests to see how damaged that sperm is within the head of the sperm. There's different tests available, and there's been different levels of research about that. You can test the sperm for DNA fragmentation, and it might tell you that 50% of your sperm, 60% of the sperm are fragmented, but you've still got a huge number that are normal. The problem is that there isn't then really any treatment in the IVF laboratory that's evidence-based that shows that you can avoid using DNA fragmented sperm to increase the embryo quality. So although you can have the test, there's very little clinically we could do in the laboratory to do anything about that. I don't know, Tim, if you can add to that.
Yeah, I mean, I think the whole sperm DNA frag is quite a controversial area, really. As you just said, I think, we don't really know what it is. There are different tests that all test it in a different way. They don't necessarily show the same results. So if you're going to have the test, which test do you use? And sometimes people will have the test and then they'll come in and say, well, what does it mean? And it's very hard to know what it actually means, because you'll have people who've had successful IVF who have a test and it's very abnormal, and vice versa, a very, very normal sperm DNA frag test, but problems with fertilization, embryo quality, and all sorts of things. So I think if a man does come in with, for whatever reason, if he's had a high sperm DNA frag, it really goes back to what I said earlier on about just focus on lifestyle. One of this Mediterranean diet is often spoken about. So just really, this should be true for men and women. So just trying to avoid processed food, the Mediterranean, more grilled, fresh food. I mean, there's no rocket science here at all. It's pretty obvious stuff. And possibly some antioxidant type vitamins on top in terms of the life. But I think a lot of it is really down to optimizing lifestyle.
Okay, thanks.
So there's a varicocele question as well, just on that. So varicocele is it's like varicose veins in the scrotum, so around the testes. And for years and years, it was felt that if there was a varicocele there, that it probably didn't really affect fertility, or if it did affect fertility, having surgery to treat the varicocele, which is normally what's required, probably wasn't of any benefit. Now things might be shifting a bit on that at the moment, and we're in a bit of a changing situation where I think we're less sure that varicoceles are not a problem. I think in some men there might be a problem with varicoceles and fertility. An issue can be that some surgeons, probably in my opinion, are very keen to treat varicoceles, perhaps over exuberant to treat them. And it's difficult to know the middle ground, really. I think if there's a man who has symptoms from his varicocele, which might be aching in the groin area or just pressure symptoms, that alone might be enough to warrant treatment for the varicocele. If you have a varicocele and some symptoms and a low sperm count or low motility, again, that might be enough to try treating a varicocele. But I think the jury's still a bit out on that, I would say.
If you had a normal sperm count and a varicocele, could it be making a difference that we can't see in the sperm count?
Well, this is the controversial bit. The studies are quite conflicting at the moment. In my opinion, if you asked a urologist, urologists are, in general, would be treat the varicocele. I think if you ask most fertility specialists, who, to be fair, often come from a gynecology background, would be more measured and say, well, if the sperm samples look completely normal, probably the varicocele is not really causing a problem. But again, it's a bit unclear, I'd say.
So somewhere that things might change in the future, possibly.
Yeah.
One question for you here, Rachel. Why do embryos sometimes suddenly stop growing? Why does that happen?
It's usually down to genetic factors. As I said earlier, embryos have to develop at a set rate. So 2 to 4 cells on day 3, 6 to 8 cells on day 3, on day 2, day 3, and then to the blastocyst. Sometimes you can get embryos that stop developing on day 3, around about the 8-cell stage. And that's because up until that stage, it's the genetic material from the egg, so the mother's genetic information, that drives that development and instructs the embryo how to grow. At 8 cells, the combined effort from the DNA from the sperm, the paternal and the maternal, has to come together. And it's called something called the embryonic genome, and it's that switches on. So if that doesn't occur, then the embryo would stop developing. And we do see that at some point, but it's usually, again, say around the genetic factors. As mentioned earlier, we do in the laboratory really try and keep the standards very high in the laboratory and optimize the culture conditions. So it would be highly unusual for embryos to stop developing because of the conditions in a laboratory. There's rigorous quality assurance and control of incubators and culture medium, and everybody monitors how that is. So it would be highly unusual that it was down to a laboratory factor. It boils down again to the genetics of the egg and the sperm.
Another question for you actually here, Rachel, which is around freezing and how you decide whether embryos are suitable for freezing, and also whether all clinics make those decisions in exactly the same way or whether some clinics might make them differently.
As I said earlier, it's really important that the embryologist can assess the embryos and see if they're good quality. And we know that embryos that are good quality have perhaps a better chance of surviving the freezing and thawing process. Although now the technology's improved and most embryos and blastocysts are frozen with a technique called vitrification now, which has very, very high survival rates. Embryologists do try and select out the ones that are good quality to give you a good chance of pregnancy as well. So it's important, I would say, to discuss with the doctor and your embryologist about the quality of your embryos so that you can make that decision together about whether you're having embryos frozen or not. But it does tend to be the recommendation to freeze the better ones. Embryologists may have slightly different grading schemes or call them grade A or grade 1, very slightly different, but fundamentally they will grade the embryos the same. And there is a national scheme which most embryologists in the UK sign up to, which send videos of embryos every quarter, and you have to grade them, and then you see if you're consistent with the rest of the country. And in there is a question to say whether you'd freeze that embryo or blastocyst or not. So hopefully that does bring some consistency into the decision making. But obviously, you know, it has to be a decision with yourself as the patient as well.
Thanks. A question for you, Tim, I think. If embryos aren't good quality, if you've told your embryos aren't good quality, but they've implanted and someone had a brief, positive outcome, but then that didn't lead to a live birth, how do they make a decision about whether it's worth going ahead with more treatment?
Well, I think the fact that there was an embryo that implanted should be encouraging. So, that's a better outcome of that cycle than if the same embryo had gone back and hadn't implanted. So I would look on that as more of a positive type of sign. I think then the discussion would be, as we mentioned beforehand, the discussion would be a thorough review with the clinic about, well, what, if anything, can be done to improve embryo quality, or sometimes egg number. I think one thing just to mention here is egg number is a big part of this. So if a low number of eggs are being collected, then by definition, there will be a low number of embryos. By definition, there'll be fewer embryos to choose from. So when we look at embryo quality at the end of the cycle, there's nearly always a range. You don't generally get 5 embryos all the same quality. There'll be a complete range of quality. So the more embryos you have to choose from, the more chance you have of choosing the cream of the crop. And that is why there have been a number of studies, in particular, many of them using the hundreds of thousands of UK IVF cycles on the HFEA database, that show that really, ideally, you want to be getting numbers of eggs about sort of 12, 13, 14 or more. And as the numbers of eggs collected drops down below about 13 or 14, the success rate does drop. And that's very much because the fewer eggs there are, the fewer embryos there are to choose from.
We've got a question here about implantation failure after a frozen transfer. How do you tell whether it's the quality of the embryo or the uterine environment that was responsible for the failure? Tim, is that one for you, perhaps?
Initially, yes, I'd have to do that. So there's a very complex interplay that has to happen for an embryo to implant. So what happens is the embryo, and this is true for a naturally produced embryo or one in the IVF lab, the embryo very much talks to the endometrium and also vice versa. But it has been shown that the embryo is responsible for most of the successes or failures. So very often understandably what will happen is patients may become absolutely convinced that there's a problem with their endometrium, but the studies show that most failures or most successes are down to the embryo, not the endometrium. Now, this has led to a whole plethora of tests that have come up with trying to diagnose problems in the endometrium in people who've had 1 or 2 failed cycles, or sometimes perhaps even before having a treatment cycle. And there's been a lot of these that have been coming through. These are types of tests that we often will review as part of our HFEA program and put onto the add-ons website. Some of them are things, for instance, like the endometrial receptivity assay. So it's a biopsy, a womb biopsy that's done at the certain time of the month when implantation should happen. And the idea is you look to see, is it optimal for embryo implantation? It looks at the genetics of the lining. And there's a big paper just being published this month a randomized paper from the States where patients are randomized to have the ERA type test or not, and there was no difference in live birth rate at all. And the talk I attended yesterday by one of the inventors of the test essentially was saying that for most patients it's probably not beneficial, but these are things that are still being marketed and sold to patients. The new kid on the block now is inflammation or infection testing of the lining. It's called the microbiome. Again, lots of different acronyms for different names for the testing. The problem with this area is it's just not been tested. So that with the ERA test, it was produced, then the studies showed it wasn't really a benefit. With the microbiome, there's Alice, Emma, all sorts of acronyms, the test has been produced, but the studies just haven't happened yet. So we're going through a bit of the same process, I think.
Thanks. A lot of testing being offered there for things that maybe people might not always necessarily need. We've got a question here, Rachel. I think this is for you, really. Someone who says that their eggs seem to fertilise but not divide. Have you heard of this happening before? And would there be a way to increase the chances of egg division?
It's really down to the genetic factors as well. So even if you get a fertilized egg, what should happen is that the egg then should divide to start the process. And I said earlier, it's the maternal, the egg side, that looks after that division and that first development up until the 8-cell stage. So unfortunately, it's probably more an egg quality. And I think you would then have to review with your doctor, depending on the age and how many eggs it was in a cycle, to whether you would then consider moving towards donor egg or a different treatment.
Another one that I think may be for you, about whether, Rachel, about whether a priming protocol such as human growth hormone or estrogen could help with egg quality. Do people do those things to help with egg quality?
I know it might be one for Tim actually about the medication that you could take. I know we get a lot of questions about, I don't think we've mentioned it yet, but DHEA for poor quality eggs. I don't know, Tim, what you feel about the evidence around that from a medical perspective.
Again, it comes back to the supplements. These are all supplements of DHEA, CoQ10. So DHEA is a very mild androgen, which is sort of a male hormone testosterone type thing, which people buy from health food shops, not usually from the UK, they import it in from the US. CoQ10 is available in the UK in sort of health food shops and things. And I'll just add it to the range of supplements we spoke about beforehand. Studies have been done on DHEA. Usually it's used as more for women with a low ovarian reserve to try and improve the numbers of eggs collected for the reasons I just said, that you want to have good numbers of eggs to get a good success rate. But the studies that have been done really don't show an improvement in live birth rate. They are poor quality studies, to be fair. It comes back to, if this was a drug, then there would be huge studies showing whether or not it definitely works. But because it's a supplement, the studies are really small studies, poor quality. So DHEA, I think no one really knows at all. And I think the same is true with CoQ10. Having said that, as I said before, if you feel happier using this sort of stuff in combination with your clinic, then probably there's no reason not to.
This one I think is for you, Tim, about what tests can be done to check the immunological response of the uterus.
So there's a whole area of reproductive immunology, and I think it's, probably, I'm sure most of the people watching now will have heard of natural killer cells. So NK cells are really, the big thing that people think of when they think of reproductive immunology. So for an embryo to implant, the immune side of the endometrium, of the lining of the womb, is very, very important. And that's because, if we think about it, if an embryo is made with the patient's egg and partner's sperm or donor sperm, half of that embryo is genetically coming from someone else. Now, if you just implanted something in your body that half of it was not genetically yours, it would be rejected straight away. So very cleverly, nature, or whatever you believe in, has worked it out so that an embryo which is genetically half not yours, is able to implant, and that baby is able to grow. Now, from that, some people have thought, well, maybe in some patients, there's an issue with the immune side of things, maybe not letting embryos implant. Now, the problem is studies just really don't support that. And so for the natural killer cells, the professor in Cambridge who reported them in the 1980s, and she called them natural killer cells, she's written a number of articles, just in absolute amazement that doctors are having patients check their NK levels within a fertility setting. She says there's absolutely no point in doing it at all. It's nothing to do with fertility failure or not. So in most clinics in the UK now, that is not tested, and it's very clearly red on the traffic light system. So for most patients who are fit and well, in my opinion, and I think the majority view worldwide, is that there really aren't any immune type things that could or should be tested for that have been shown to be beneficial. If someone has an underlying serious immune condition themselves, that's a bit different, of course, but for most people, I think there's no benefit.
Someone's saying, is there anything at all aside from age that's been proven to influence egg quality in the months ahead of collection? Is there anything at all, I suppose that's asking, that patients can do that would make a difference?
Rachel?
I mean, we've talked about supplements, haven't we, and the lack of evidence. And as I said, you're born with those eggs. As you get older, the embryo's eggs diminish in quality, and there's nothing that you can do to reverse reproductive aging. Tim mentioned earlier about having a healthy lifestyle, a healthy diet, and Mediterranean diets, but it's doing everything in moderation, isn't it, Tim, and being sensible about that approach. But unfortunately, you can't reverse poor egg quality.
One thing, just I've not mentioned folic acid, so it is really important that women who are trying to conceive do take folic acid, and it's, again, most of the pregnant care, well woman type things are going to have that wrapped up within it as well. Just be careful that if you are taking some more specialized fertility ones that perhaps you're buying directly online, they may or may not contain folic acid as well. So folic acid is not it's not a supplement that is helping you get pregnant, but it certainly makes a difference to reducing the risks of some very severe complications during pregnancy for the baby.
We've got another question here about sperm DNA fragmentation, which I know we've talked about, but someone asking if there is sperm DNA fragmentation problem, is ICSI enough to combat that?
Again, research is limited, and there's different thoughts around that as well. So if you've got a high concentration of DNA fragmented sperm, in ICSI, of course, the embryologist is picking the sperm up and putting it into the egg. In IVF, you leave hundreds and thousands of motile sperm around the egg, and it may be that there's a survival of the fittest, that maybe the better sperm fertilise the egg, and just normal IVF can be beneficial. But there just hasn't been the studies done to say which one is better. And certainly from a HFEA and science perspective, ICSI should really just be used for male factor infertility, where the numbers are reduced or the number that are motile is reduced.
I mean, I'd agree with what Rachel said, though. Quite widely, so often what will happen is the companies who sell the DNA fragmentation tests, in the results, it will say if it's high, ICSI will be recommended. So that is where that often comes from. But as Rachel said, there's really no very good evidence for that. There's some quite poor quality evidence suggesting that ICSI may be beneficial compared to conventional IVF with high sperm DNA frag, but then they're not good quality studies. So you always need to be wary of basing too much on them.
This is an interesting question for you, Rachel. Does an embryo have to divide in twos? Does it have to go 2, 4, 8, etc.? Someone's saying they've got embryos that are 7, 9, 11. Does that matter?
That's absolutely normal. The embryos will go 2 to 3, 4, 5, 6. We say, on day 2, we expect it 2 to 4 cells, and then, but yes, you will always get the uneven cells. The time-lapse research around that has shown the timing of those divisions can play in towards embryo quality. So the embryo is meant to divide quite quickly between 3 to 4 cells. What you don't want to happen, and again, we've picked this up from the time-lapse videos, is that embryos should always go to 2 cells first. What you don't want an embryo to do is go directly to 3 cells. It's thought that then the number of chromosomes in those cells won't be right, and that's not going to be good for the embryo's genetic health, even though it might develop normally. So yes, don't worry if you've got a 7-cell embryo, a 9-cell embryo. It's just when the embryologist just happened to take that snapshot.
That's really reassuring. So I think that's something that people do worry about a bit, actually. There's another really interesting question here, Tim, which I think is one for you, which also comes up quite often, which is, given that the number of eggs is finite, does ovarian stimulation and egg collection during IVF bring forward the menopause?
It's a really good question, and I get asked that question by non-fertility doctors as well sometimes, actually. So it's not as, it's actually a really good question. So as Rachel mentioned, women are born with a couple of million eggs in the ovaries, and the numbers of eggs in the ovaries actually starts going down from before birth. So the maximum number of eggs in the ovaries is actually at about 6 months gestation in the mother's uterus, and then it starts going down from before birth. Now, obviously, women, or young girls are not ovulating, so they're not losing eggs by ovulation. These eggs just die off on their own in a natural, programmed way. That's the reason, because women don't have 2 million ovulations, or 2 million months of cycles before they have the menopause. These eggs are dying off. So even if you had 10 IVF cycles with 15 eggs collected, losing 150 eggs out of starting off with a couple of million, is making zero difference. So there's no link between having IVF treatment cycles and bringing on an earlier menopause.
And of course, every cycle, if without IVF, you ovulate one egg and one follicle grow, but a lot of less developed follicles still grow and then diminish to let that one follicle go in. So it's naturally only producing, when you stimulate an ovary, you're bringing those follicles on that were perhaps there anyway.
We've had a couple of questions about PGS, whether you agree with it, but also what you would do if you had PGS about mosaic or aneuploid embryos. Tim, I wonder if that's one for you first.
Yeah, so just to explain, so PGS is the old term for PGTA. So PGT is pre-implantation genetic testing. So you get embryos to the blastocyst, you make a hole in the outside of the embryo, you take some cells away, and then you analyze the genetics of the cells, and therefore giving you an idea of the genetics of the embryos. It's very commonly done for people with inherited disease, so history of cystic fibrosis or what have you, and that's called PGT-M. PGT-A is when it's being done to see just purely is the embryo abnormal or not, just through charts, as Rachel said at the very beginning. Now, it has been really controversial over the 30 years or so that it's been around as to whether PGT-A helps improve success rates. We know that even for a woman in her mid-30s, a woman in her mid-30s producing embryos, on average, surprisingly, on average, around half of those embryos are chromosomally abnormal. So again, you'd think that logically, doing a test that says yes, no, no, yes, must improve the live birth rate. But the studies that have been done, the randomized studies, where half the people have PGT-A and half don't, for women in their 30s, there is no difference, there's no improvement in live birth rate. That may be partly because we're having to do a biopsy, we're having to do other things to these embryos. Now, the other thing you mentioned was mosaicism. So mosaic is like a mosaic tile. It's a patchwork of different things. And we know that it's very common that embryos will have different types of cells in. Some cells might be chromosomally normal, and some cells might be chromosomally abnormal with the wrong numbers of chromosomes within. And an issue for PGT-A has been that you can get results back suggesting that the embryo is not entirely normal or entirely abnormal, but it's mosaic. It's got a mixture of cells. And there's been controversy about what should you do with that. Should these embryos be put back at all, or should they be discarded? And this is one of the downsides of PGT-A, because potentially you do a biopsy, you find an embryo is mosaic, you then think, well, let's not put it back. But we know that mosaic embryos can sort themselves out and can lead to completely normal, genetically normal, healthy children. So this is it's a hot topic now, but it's been a hot topic for 20 or 30 years, to be fair, as well.
Rachel, would you have anything to add to that, just around how people make decisions about the embryos? If you're told an embryo isn't completely normal, how do you make the decision about when to transfer and whether to transfer?
I think the knowledge has improved, hasn't it? That we know, like exactly what Tim said, even a mosaic embryo can go on to produce a genetically healthy baby. So it's really important that you talk to your doctor about it and understand. It might be that if you've got an embryo that is normal and is euploid, normal number of chromosomes, that has a higher chance of having a baby or a less chance of having a miscarriage. But I know, I've had the question where somebody said that all their embryos were mosaic, and did that mean that they all had to be, they couldn't use them? But that's a conversation that you'd have with the doctor embryologist, and you might accept the risk that there might be a higher chance of a miscarriage. But I think there's a conversation to be had. I think what we've learned is that it's not so straight cut as it used to be years ago, where it was normal or abnormal and you just had the normal ones back, because actually some of those abnormal ones could have gone on to form a healthy pregnancy. Just
to say, if you're in a clinic that's doing PGT-A, then they should be fully able, the fact they're offering PGT-A, they should be fully able to discuss with you all the types of results And if they can't, then they should facilitate a genetics counsellor to have that discussion with you.
That's really useful to know that people can actually ask for that if they want that kind of input. Talking about miscarriage, there's quite an interesting question here, which I think, Tim, might be one for you. Do good quality embryos have any impact on reducing the risk of miscarriage?
This is so driven by the age of the eggs that made the embryos. And going back to what you said right at the beginning, you can have, it might be the 44-year-old woman might make, with her own eggs, might make beautiful looking blastocysts, but the proportion of the embryos that are chromosomally abnormal will be very, very high. And if there's embryos implant, then the miscarriage rate will be very high. So in terms of, is there a link between embryo quality in terms of how it looks and miscarriage rate? I would say if there is a link, it's a very low, very poor link, because embryos that are very poor quality in terms of how they look, they probably won't implant because they just won't keep on dividing through the implantation stage and beyond. And I think, if they make it to 6 or 7 or 8 weeks, I think then if the miscarriage happens, it's due to something else, not due to how the embryo was on day 5.
An interesting question here, Rachel, from someone who says they tend to get a lot of fragmented embryos. And would that be an egg quality thing or a sperm thing?
Fragmented embryos is when an embryo splits between 1 cell to 2 cells. It's when little bits get left behind, so the cells sort of go lower in number. And a little bit of fragmentation is absolutely fine, but the more fragmentation that are there, then the less likely the embryo will have enough cellular material to go on to form a good quality blastocyst, and then for it to go on to implant. So there is a problem there. It's difficult to understand the source of where that comes from. It can be an egg problem. I think we don't know an awful lot about the sperm quality. I think that's the problem as well. But it does tend to be, I would say, more an egg problem. But again, it's difficult to pinpoint exactly where that is sometimes.
Tim, we've got a question from someone who's very sadly had 2 experiences of miscarriage in their 40s, and said, do you think that it's more likely to be an underlying issue, some problem going on? Is it more likely to be egg quality due to age in your 40s?
So I ran the recurrent miscarriage clinic here in Oxford for about 10 years or so, where we just saw couples with 3 or more consecutive miscarriages, and we investigated all of them in the evidence-based way with blood clotting testing for the woman, thyroid checking, detailed scans of the uterus for polyps and fibroids, all that sort of stuff. And it actually was very unusual that you found an underlying cause outside of thinking, well, probably this is chance on a background of age. As an example, there were hardly any patients in their 20s, where the woman was in her 20s, that had recurrent miscarriage. It was very unusual. And that's because the miscarriage rate per pregnancy is very low for women in their 20s. Most people we saw in the recurrent miscarriage clinic, the woman was in her late 30s or into her 40s, really because the miscarriage rate for one pregnancy had gone quite high, and therefore, sadly, it's more likely to happen. Now, when people come into the clinic, often they're wanting us to find an abnormality with testing, but I always flipped it around and said, I don't want to find an abnormality. All the studies show that in people who have a history of miscarriages, if you find an underlying problem, you may or may not be able to fix it. And if you can fix it, all you're doing is bringing the success rate back up to what it would be if everything was normal in the first place. So in general, any tests that are done for recurrent miscarriage, and that's very much blood clotting tests for the woman and just confirming the scan, the pelvis looks normal. Very often the tests are really done as more of a reassurance. And I've been more reassured for your case, who wrote the question, that you did get pregnant. Because again, if you're getting pregnant, it means there can be a chance of success. Now, just the very last thing to say is, for years and years, there's been a question over whether giving progesterone during pregnancy is of any benefit in terms of reducing the miscarriage risk. And we generally said no, it wasn't, because it felt it wasn't. But a recent UK study called the PROMISE trial looked at giving progesterone to women who had conceived, who had a history of miscarriage, and who had bleeding in pregnancy. And it suggested that giving some progesterone during pregnancy may reduce the miscarriage rate. Now, most fertility patients are going to be on some progesterone anyway. I guess if you have a natural cycle, frozen cycle, so a natural frozen cycle, you might not be on some automatic progesterone. And if you have a history of miscarriage, there might be a question you could have to the clinic.
Thank you. Rachel, interesting one for you here. Can EmbryoScope improve embryo quality because the embryos are disturbed less if you're using EmbryoScope?
It can't magically improve it, but what it can make sure is that they are kept in the optimal conditions so it doesn't decrease the quality. And I always think, again, the studies, there's some information on the HFEA traffic light. The EmbryoScope, or the time lapse, is rated amber, which shows that there's some emerging evidence or some conflicting evidence. But logically, I like to think an embryo likes to be kept at body temperature. It likes to be kept in very certain environments. And if the embryologist is taking that out of an incubator and walking across the laboratory and writing down, it could be that that embryo is being compromised very slightly because of that change in the atmosphere. So in theory, when you think about it logically, if it's in an incubator, it's safely in there, it does create a safe space for it. But I don't think the research is there to back that up. There haven't been good quality randomized controlled trials which show a normal incubator to an EmbryoScope without all the information, looking at the grading as well of that. So logically, you can see how it would do that. But again, the evidence is limited still.
Tim, we've got a question here about AMH, someone who's got low AMH but can produce good looking embryos. Does low AMH automatically mean low quality eggs and abnormal embryos?
It's a really good question. So as we mentioned a few times, women are born with a couple of million eggs. The numbers of eggs goes down over time. And the numbers of eggs remaining is often called the ovarian reserve, so reserve of eggs that are there. And there's different tests for that. The old-fashioned test is an FSH, follicle stimulating hormone blood test. Problem is it just goes up and down all over the place. It's really hard to work out what it means. The second test is a scan of the ovaries to look at the numbers of follicles in the ovaries. That's called the antral follicle count. That's better than FSH, but there's quite a lot of variability between who does the scan and what time of the cycle. The best test is a blood test called AMH, anti-Müllerian hormone. So AMH is a hormone that comes directly from the ovaries. It's in the blood, and therefore, it's a very accurate measure. So we know that AMH is important before an IVF cycle because it helps us decide the type of drugs to use, the dose of drugs, and gives an idea as to the risk of overstimulation, the numbers of eggs that are going to be collected. So AMH is probably the most important pre-IVF test that there is. Now, AMH is not related to egg quality, however, and a good example of that is that AMH is not related to the chance of natural conception. So women can have a very low ovarian reserve or a high ovarian reserve, and if they're having a regular cycle each month and releasing one egg each month, it doesn't matter whether there's 500,000 or 2 million eggs in the store, there's one egg coming out each month. The importance is the age of the egg. The number of eggs in the store, which is really what AMH measures, is pretty irrelevant. Numbers of eggs in the store is important for IVF because we want to get a good number of eggs, but for natural conception is pretty irrelevant. So AMH is an egg number thing, it's not an egg quality.
That's really interesting, thank you. Someone's just asked the question, are there any supplements that medical professionals actually do recommend women take? I think we've talked quite a lot about what people might not take, but is there anything that you think people definitely should take?
I always feel a bit negative on it. I always really, whenever I'm asked it, I always feel, very no, don't take anything. Again, as I said beforehand, I think taking something is not a bad idea, but I think the well woman, well man, pregnant care, conception type stuff, it's got calcium in it. On the female side, it's got folic acid, it's got calcium, it's got vitamin D. On the male side, it's got a bit of zinc, all the stuff that may well help fertility, but probably in most people's diet, they have enough of anyway, apart from folic acid for women. So my general advice is yes, maybe take something, but just something straightforward from a chemist. I personally don't suggest to my patients they go off, seeing a nutritionist and spending loads of money getting supposedly very individualized supplements where there isn't any evidence that that is any better than probably a normal diet or pregnant care or well man, well woman.
Thanks. I think this might be another one for you, and it's quite an interesting question about being older and the impact of weight on egg health. Someone saying, is it best to wait to get to the optimum weight for treatment, or is it best to just go ahead if you're older anyway?
That's a very, very good question, because that's a sort of a real life scenario. So as women get older, then obviously egg numbers are going down, as we said, but the egg quality does drop away quite quickly. So I think it depends very much on how much weight we are talking about losing. The issue with weight is, I would say, not so much about egg quality. We know that as a woman, if a woman has a high BMI and she's going into an IVF cycle, on average, she'll have fewer numbers of eggs collected because the drug just has more to go around. So the drug is less concentrated, so fewer eggs collected. If it's a very high BMI, above 35 or so, then the egg collection is riskier because it's harder to see the ovaries. So there are more risks of infection and bleeding. And very importantly, the pregnancy is more risky. So the embryos are less likely to implant. There's a higher risk of miscarriage and a higher risk of complications like diabetes and high blood pressure and bleeding in pregnancy. That's why the NHS wants your BMI to be less than 30, and most private cycles BMI less than 35. I'm aware some clinics will have a less than 40 type thing. That's why. So in terms of whether you should focus on weight loss or cracking on with IVF, I think depends on really how old you are and how long realistically it is going to take you. You know, to drop from a BMI of 40 to 35, it's going to take a fair amount of time. But having IVF with a BMI of 40, I think, is a bad idea because of the risks. So I think this has to be a discussion with the medical team looking after you.
Thanks. I think we've probably got time just for one last quick question, and this is one for you, Rachel. Do you feel all labs are equal in how they work to maintain egg, sperm and embryo quality, and how do we know how good a lab and embryology team are?
Well, in the UK, we do have the HFEA, who I'm currently the Director of Compliance, and we have a team of inspectors who go out and we have to go and visit a clinic every 2 years, and we will assess how they're functioning and look at the quality and all the checks that they've got in place to make sure that their lab is functioning as it should. And then, of course, we do monitor success rates from clinics. We have the Choose a Fertility clinic facility on the HFEA website, which gives the clinics success rates for normally a couple of years ago, because we're looking at live birth rates. So there are measures in place to make sure that a clinic looks at the right quality indicators, have the right what we call key performance indicators, so that they can look from a quality perspective, and we would expect clinics to audit them. The other good thing about the UK is that we do have very good embryologist training schemes. We have the scientific training programme, which is a government-based master's qualification, where the embryologists really go through rigorous training and competency assessments before they get signed off. So you can look at a clinic's inspection report, again on the HFEA website, to see if a clinic has any problems, but there should be consistency and a high level of quality of care in the UK with laboratories.
Thanks, that's really useful. So patients don't need to go around doing their own research onto this. They should be able to be reassured, basically.
Yes, a lot of the clinics now are groups as well, and the groups will work together with their individual clinics to help raise standards and look at how they're doing. It's about being open and honest and transparent and learning and sharing expertise as well.
Thank you. Thank you, Rachel, and thank you, Tim. Thank you both for joining us and giving up your time to talk to us this evening. We've had so many questions. I'm really sorry we didn't manage to answer all of them. I think we would have been here all night if we had, but maybe this is a topic we can come back to another time. Just to say that this webinar will be available on our website, hopefully in the next few days. You can look in the webinar section of the website to find it. If you found it helpful, you can now text to donate. As I said, we're a charity, and we would really, really be very grateful if you do feel able to do that. You can text FNUK and then the amount you want to donate to 785. So that's 785 and then FNUK with the number of however many pounds, whether it's 1 FNUK 1 or 5 FNUK 5. We'd be really grateful. So that's 785. But thank you all.
Can I just check on that? Is that 70085 or 785?
Yes. 70085, 785, 70085 is the number to text, and it's FNUK and then just the number. But thank you all so much for joining us. It's been really lovely to have you with us, and it's been great to have Tim and Rachel. Thank you so much for your time. So thank you and good night.
Good night.